talking about how do we differentiate functional heartburn from gastroesophageal reflux disease. A lot of it, I'm going to talk a little bit about what is functional heartburn and some of these functional disorders, and also how we actually approach patients in evaluating for reflux symptoms. So first of all, think about what esophageal symptoms we encounter in our clinic. There are a number of different symptoms, either GERD-related symptoms, maybe swallowing symptoms related to EOE, maybe related to esophagitis of different reasons, including medications, maybe some obstructive motility disorders. We just talked quite a bit about it. And there's also other symptoms, maybe chest pain or burning, that's more related to either dysmotility or hypersensitivity, and some functional chest pain and functional heartburn symptoms. So you can really categorize them. The top ones are really the ones that are due to some type of underlying organic diseases or underlying causes. And the bottom ones are more of the functional disorder that we think about. There's no organic causes per se, and a lot of it may be due to increase in sensitivity of the esophagus. So what are the mechanism of causing these functional disorders? Usually it will start with some type of peripheral noxious stimuli or some type of provoking stimuli to the esophagus. And it usually involves some sort of abnormal central processing, including autonomic reactivity, which then lead to these functional symptoms, or now we call them disorders of gut-brain interaction. And there are also maybe other potential modifiers that may amplify some of these abnormal processes, including cognitive factors, psychological factors, stress, emotional factors. Sleep can actually increase a lot of these functional symptoms. And so what are some of the common pathophysiologic elements that cause these? Some of these include visual hypersensitivity, if they're more sensitive than usual. Maybe certain type of mucosal triggers can amplify these symptoms. Psychiatric comorbidities, some motor abnormalities or dysfunction may actually increase the sensitivity or some of these symptom severity. And also, now there's some data on the anatomical location of these sensory nerves in the esophagus that might contribute to these functional symptoms. So there are some studies looking at visual hypersensitivity. This is a study looking at perception of the esophagus. What it involves is a catheter in the esophagus, and it was distended to look at when the patients start feeling pain or feeling something sitting in their esophagus. So looking at the mechanosensitivity. And what you can see here is that on the left-hand side is when the patients first feel something in the esophagus. On the right-hand side is when they first feel pain. The thing I want to highlight is that if you look at the functional heartburn group, which is the graph in the green, the volume where they start feeling something is much lower than the other conditions, including in control patients. So maybe an increase in sensitivity, a decrease in perception threshold is one of those things that can cause these functional symptoms, including functional heartburn. What about mucosal triggers? This is another study where it was utilizing a barostat balloon. So again, a balloon is put in the esophagus, it's inflated to see when the patients start feeling pain or start feeling something sitting in their esophagus. And these patients were given acid and saline were infused in there, and see what happens when you infuse with these things and what happened to the perception threshold. It turns out that the group where you infuse acid in there, their perception threshold of when the balloon is distended is much lower, and so is the pain threshold. But when you infuse it with saline, it didn't really change very much. So maybe acute acid exposure or some other mucosal factor can sensitize the esophagus to these mechanical distension and make them feel things in their esophagus or feel these stimuli much easier. There are also psychiatric comorbidity that we mentioned. This is a study looking at patients with either non-cardiac chest pain with or without cardiac or esophageal finding. And what you can see here is that a significant proportion of these patients with non-cardiac chest pain have some type of underlying psychiatric diagnosis. This is another study, this is actually a meta-analysis that we published last year, looking at a lot of studies of patients and their underlying psychiatric diagnoses. And what we found was that when you look at patients with non-erosive reflux disease compared to patients with erosive esophagitis, the patients with non-erosive reflux disease are much more likely to have an underlying diagnosis of anxiety. So psychiatric comorbidities are quite prevalent in these patients with functional disorders of the esophagus, and something to think about. What about motor patterns? It turns out some esophageal motor patterns may actually predict esophageal sensitivity. For example, spasm, patient with hypercontractile esophagus that we talked about. A lot of times they can, in addition to causing their symptoms, they can also have an increase in sensitivity. This is a study looking at the contraction vigor, how strong the contraction is, and their pain sensitivity. And what we can see here is that the stronger the contraction, the higher sensitivity to pain these patients have. So it seems like certain motor patterns, specifically hypercontractile pattern, may also increase the sensitivity of the esophagus. There are also some very interesting study looking at what the nerve endings are in the esophagus. And it turns out that when you look at patients with non-erosive reflux disease compared to patients with erosive reflux disease in healthy controls, the nerve endings are much closer to the surface of the esophagus than patients with their normal healthy controls or with erosive reflux disease, meaning that maybe these patients have a higher sensitivity because their nerve ending are closer to the lumen and more likely to be triggered. So how do we distinguish these patients with functional esophageal disorders to patients with more organic conditions, patients with underlying diseases that may be causing their symptoms? There are some clinical features you can think about. Age and gender. Usually patients with functional disorder tend to be younger. They're more likely women. The time of onset might be also very different. Patients with organic diseases oftentimes have a very acute or precise onset of symptoms versus patients with functional symptoms, it's a lot more poorly defined. Oftentimes they can't really tell you exactly when it started. They may have the symptoms for years and kind of lingering. The symptoms are more specific for patients with organic diseases versus is usually more diffuse, and they often complain about multiple things in patients with functional conditions. Oftentimes they also have other functional syndromes, so it's common for patients to come in with functional heartburn symptoms who may also have IBS and some other functional disorders. We talked about psychiatric profile. For patients with functional disorders are more likely to have psychiatric comorbidities. And they're also more likely to report intolerances to specific diet. A lot of times you tell them, well, if you avoid this food, what happened to your symptoms? They will tell you that, oh, I've tried all of them. I can't tolerate all these foods, and they might actually be losing weight because they're avoiding a lot of food because of their symptoms. Usually functional disorder patients have more poor and suboptimal therapeutic response, and they're more often to be unsatisfied from the treatment response. And what are some of the predictors, if you think about it, like predictors of functional heartburn? This is a study looking at almost 700 consecutive heartburn patients, and they underwent reflux testing to get classified into those with functional heartburn and true reflux disease and patient with reflux hypersensitivity. Basically, the predictors of functional heartburn in this cohort is if they have also have IBS, if they smoke, and also if they have anxiety, or hydrohernia, anxiety. If they have a hydrohernia, they're less likely to have a functional disorders, or more likely to have abnormal reflux. So how do we diagnose these patients? Well, first of all, per Rome criteria, a lot of these patients, they should have at least 3 months of symptoms with onset at least 6 months earlier. So these need to be chronic symptoms. You need to think about excluding any structural mucosal abnormalities. So you might think about doing endoscopy or barium studies to exclude them. Exclude GERD or EOE, potentially as a mechanism of their symptoms. So maybe EGD with biopsy or do reflux monitoring. And also excluding any major motor disorder. That's where manometry and barium might help, and maybe even flip. So overall, how do we approach these patients? A lot of times when patients first come in, you have to really ask them about their symptoms, what the symptoms are like. Look for any alarming symptoms. If they have signs of bleeding, acute weight loss, those are some of the things you think about doing more testing sooner. Try to limit routine testing up front. You don't really have to test every patient for everything up front to make this diagnosis. A lot of times by symptom itself, you can actually identify patients who might more likely have functional symptoms. Think about the clinical features that we just talked about between organic and functional disorders, and think about whether or not they have underlying psychological factors. You can also think about doing some empiric conservative management, like lifestyle and dietary interventions. Think maybe an empiric trial of acid suppression. And if they still have symptoms by doing this, or if they have alarming features, then you can think about doing some more investigations. And how do we investigate it? Well, first of all, we want to basically distinguish those with true abnormal reflux and those with functional disorders. There are a number of ways that we assess reflux. Upper endoscopy, esophageal manometry may help, and also reflux monitoring study. So what do we look for in upper endoscopy? I think we're all very familiar with these patients with high-grade esophagitis, per Leon classification, anything that's LA grade B, C, or D esophagitis, or other GERD complications like peptic strictures or signs of Barrett's esophagus will give you, will suggest abnormal underlying reflux. Manometry may be helpful. We talk quite a bit about manometry, but there are certain features of manometry that might suggest reflux have been associated with abnormal reflux. For example, if they have a hiatal hernia, if they have hypomotility, such as significant IEM or absent contractility, or if they have hypotensive EGJ, they're more likely to have abnormal reflux. We also talked about maybe helping with reflux monitoring probe placement or evaluating for anti-reflux surgery. That's where esophageal manometry might be helpful. How about reflux monitoring? Well, there are actually two main classes of testing modality that we can consider for doing reflux monitoring. Either you can do a wireless pH monitor or a 24-hour combined pH impedance monitor. The differences between the two, and there are advantages and disadvantages between the two. Wireless pH monitoring, you really focus on acid exposure, whereas pH impedance monitoring, you can actually look at both acid and weakly acidic or non-acidic reflux, as well as looking for things like proximal reflux. You can also assess baseline impedance, which we will talk about in a second. With a wireless pH monitor, because they're more comfortable, you can do a more prolonged study compared to a pH impedance study. The other, one disadvantage is that for pH impedance study is the discomfort, because patients are walking around with the catheter sticking off their nose. So a lot of times patients might not be eating or doing their daily activity normally, so that may affect the accuracy of the result. And also you lose the day-to-day variation from the test. So this is an example of a wireless pH monitor that you might be familiar with, and you can look for when pH drops below 4, which is the acid reflux episodes, and also look for acid reflux episodes that might correlate with symptoms at the same time to do symptom correlation. pH impedance, Dr. Gorali talked a little bit about what impedance actually is. It's a measurement of basically electrical resistance. So liquid, which has a high conductance, tend to have a low resistance to electrical current. They will have a lower impedance compared to air, which has a higher impedance. So whenever you look at the impedance monitor, you see a drop in impedance, then there might be liquid passing by. And with that, you can actually look at when liquid comes up the esophagus, you see a drop in impedance kind of marching from the bottom of the esophagus to the top of the esophagus. And you can actually classify them as weakly acidic, non-acidic, or acidic reflux episodes. We talk about prolonged reflux monitoring and why prolonged monitoring may be relevant. This is a study looking at patients who underwent wireless pH monitoring, and it started out with 50 patients. Out of them, 35 underwent a full 96 hours, the rest of them only 48 hours. And anything with the acid exposure time in this study greater than, I think this is 5% here, was classified as NERD. But the main thing to focus on really is that if you look at the pattern of how these acid exposure time changes over the 4 days, there are some patients, a lot of patients where the first 2 days are in the normal range. When you get to the 3rd and 4th day, they will actually have days when they actually go higher into the abnormal range. So the main thing is, you know, if you do a prolonged study, the diagnosis may shift when you get to the later days. So if you do a short study, you might miss those patients. So increasing the number of days of the pH monitoring will increase the sensitivity of diagnosing patients with abnormal reflux. Another metric that we didn't talk quite as much about is baseline impedance. We talked quite a bit about impedance, but the baseline impedance of the esophageal mucosa may also be an important marker. It is thought that it might be a marker of esophageal mucosal integrity. So if you just measure the impedance when there's nothing going on, there's no swallowing, there's no reflux, it might estimate how intact the esophageal mucosa is. The more damaged the esophageal mucosa is, the lower the baseline impedance is. So when you have a patient who have more reflux, they may have more mucosal damage, they may have lower baseline impedance. And this has been looked at in patients where with and without reflux, and have been proven that patients with abnormal reflux will have lower baseline impedance. And there are two ways of measuring it. One is on pH impedance study. We can measure a metric called the mean nocturnal baseline impedance. Usually at night when patients sleeping, there's nothing going on. That's a good time to measure the baseline impedance. There's also another technology where mucosal impedance can be measured through a probe during endoscopy. And there are a number of studies looking at how baseline impedance may help you classify patients. Here you can see that patients who are functional heartburn, which is the FH patients, all have higher mucosal impedance or baseline impedance compared to the other groups, telling you that they are more likely to have an intact esophageal mucosa, maybe less damage from reflux. So on reflux testing, outside, these are the number, when you do reflux testing, depending on which modality you use, these are some of the parameters you can look for. But the ones in red are the ones that are truly important in helping you classify patients. The acid exposure time, the total number of reflux episodes and impedance. We talk about the mean nocturnal baseline impedance, and also looking at symptom association during reflux testing to help you classify patients. One of the first things you think about though when you test patients with reflux is, do you want to do the testing on versus, do you want it on PPI or on acid suppression versus off acid suppression? And this is actually very important because you might interpret these tests differently. Really, the idea is that this concept of proven versus unproven GERD should drive how you decide which protocol to use. Basically, patients with unproven GERD, basically you don't know if they have abnormal reflux yet. The question you have is, does the person have increased GERD or pathologic GERD? For patients with proven GERD, meaning that you already know they have reflux, they're not responding to medical treatment, the question becomes, is there persistent reflux due to refractory to optimal therapy? The criteria for unproven GERD is that they have no known evidence of GERD on objective testing, including endoscopy or reflux monitoring, versus the group of proven GERD is they have some type of prior objective evidence, not just by symptoms, but true objective evidence of reflux. And so for the group with unproven GERD, you want to do them off PPI because you want to first prove that they actually have reflux. For the second group, because you already know that they have reflux, you can do the test on PPI to see why they're not responding to medical therapy. And these are some modality you can use when you do choose between on versus off PPI testing. And how do you define GERD? And this is adopted from the most recent Lyon consensus, where you can use parameters from endoscopy, from pH impedance study, or manometry to help you classify patients into those with abnormal reflux or not. Patients with conclusive evidence of reflux, we know when you see these, we know that they have abnormal reflux. Are patients with high-grade esophagitis, complications from reflux on endoscopy, or if they have an abnormal reflux monitoring study defined as an acid exposure time greater than 6%. On the other side is you have evidence against abnormal reflux, and this is when patients had acid exposure time less than 4% during the study, or if there's a very high mean nocturnal baseline impedance defined as 2,500, greater than 2,500 ohms, or if they have less than 40 total reflux episodes a day. When you see these are evidence telling you that they're unlikely to have abnormal reflux. And there are also other parameters that are borderline or supportive. So when you have patients with acid exposure time between 4 to 6%, for example, and that's considered borderline, then you look for any other supportive evidence or adjunctive evidence of reflux that might then help you diagnose their GERD. So this is a very a more easy to use way to really classify all these metrics to help you determine if they have abnormal reflux or do they not have abnormal reflux. And that is when you can phenotype the patients into groups that have GERD or NERD versus functional heartburn or reflux hypersensitivity. So patients who have an increase in reflux burden, so they have pathological reflux, with or without symptom association, they had abnormal reflux. They have GERD or non-erosive reflux disease. If they have evidence against pathologic reflux, they don't have GERD, but they have a significant symptom association, those are patients with reflux hypersensitivity. If they have evidence against pathologic reflux and their symptoms do not correlate with reflux episodes going on at the same time, those are the patients with functional heartburn. So this is a way to really phenotype these patients. So with that, then we can think about how we can employ these testing to help us to distinguish patients with functional heartburn or functional disorders from abnormal GERD. So if you have a patient with heartburn or chest pain and they do not respond to PPI, first test you can do is do an upper endoscopy, rule any abnormality on biopsies or any organic lesions. If there's abnormal, you treat that. If the endoscopy is normal, then you think about doing a set of reflex testing like pH, ambulatory pH testing or pH impedance testing. If that's abnormal with a positive reflux symptom association, but a normal acid exposure time, those patients, you can classify them as reflux hypersensitivity. If they have an increase in acid exposure time to greater than 6%, those are patients with GERD. On the other side, if you have borderline acid exposure time between 4 to 6%, then you look for these adjunctive parameters, like this supportive evidence of GERD. And if they do have them, then you can diagnose them with GERD as well. But if they don't have them, or if they have a normal AET of less than 4%, then you want to look for any motility disorder, do a manometry. And if that is also normal, those patients have functional heartburn, or if they have no evidence of reflux or reflux monitoring. So this will be an algorithm of using these tests to distinguish patients to those with GERD, reflux hypersensitivity, as well as functional heartburn. So in summary, we know that functional disorder may be associated with a wide range of pathophysiologic risk factors that may include visceral hypersensitivity, psychiatric comorbidity, maybe some motor abnormalities or sensory neuropathy. Initial management really should include assessing for any alarming symptoms, maybe try an empiric trial of acid suppression, consider these psychological comorbidities and treating them. Testing really should be reserved for those with alarming symptoms, or you have a high suspicion of an underlying organic disease, or if they fail empiric treatment. And when you do testing, you should evaluate for signs of mucosal disease, obstructive processes, maybe motility testing. And really, objective evidence of abnormal reflux from these testing is what truly distinguishes GERD from the functional heartburn patients. Thank you.